Sale works at Kenyatta National Hospital, Department of Laboratory Medicine in the Histopathology and Cytology section. And she also does part-time teaching at Jomo Kenyatta University of Agriculture and Technology. She has undertaken BSc in Medical Laboratory Sciences from MKU, and Masters of Science in Clinical Histopathology and Cytology from JKU Art. She's passionate about histopathology and cytology, and this is the exact area that she's presenting to us this evening. And when she's not doing lab work, she loves reading and hiking. So help me to welcome our presenter this evening, Christine Osale. Christine, I would like you to take it up from here and present.
Thank you, Nelly.
You're welcome, Christine.
Thank you so much for the wonderful introduction. And I'll just join you in welcoming our presenters to today's webinar. Our listeners to today's webinars, good afternoon, everyone. My name is Christine, as Nelly has said, Osale. Coming to you from Kenyatta National Hospital, Department of Laboratory Medicine, Histopathology Laboratory. Today's topic is intraoperative diagnosis, and we are going to look at this in a histology laboratory perspective. What is that crucial role that histology lab will play in intraoperative diagnosis? So welcome, and let us start. So objective for the day. Today we are going to look at the role of histology in intraoperative diagnosis. Another objective will be cytological techniques in intraoperative diagnosis, frozen section technique and its application in intraoperative diagnosis. Then the key considerations for intraoperative diagnostic procedures. An overview. So what is intraoperative diagnosis? This is just a real-time assessment of tissues or cells during a surgical procedure. Real-time assessment of tissues or cells, meaning the diagnosis has to be done intraoperatively when the patient is on the operating table. I want you to figure out a patient being on an operative table. The surgeons are there, the patient is open, and a sample is taken, and the results, and it has to be processed, and the results have to be communicated when the patient is still open on the operative procedure. So that is basically what intraoperative diagnosis means. We take a sample when the patient is on the operating table, the sample is processed, and the results are released immediately. And the results are going to aid the surgeons to make important decisions concerning the client. So that's what basically intraoperative diagnosis means. So why is it important? It's important because it's going to guide the surgical decisions, because the surgeons are there waiting for the pathologist to communicate the feedback or the results for the sample collected. So the results are going to guide on the surgical decisions. They're also going to confirm or refine preoperative diagnosis. Maybe the surgeons were thinking it was a benign tumor or a malignant tumor, or it was maybe a fluid. So maybe it's an infection. So that particular diagnosis is going to help them just confirm their diagnosis or what they were thinking the patient is having. Another importance of this, it will ensure adequate tissue removal or sampling. When you're assessing the tissue, when you remove a tissue, then it's taken to like a biopsy is taken, or a fluid is taken for the FNA sample is aspirated, then it's done intraoperatively, right? Like you do the quick assessment, processing of the sample, then you report the results. We call it ROS, results on site. When you do the ROS, and then you communicate the findings to the surgeons, and then you tell them the sample you collected was non-diagnostic. That means they have to sample adequate another tissue, like when the patient is still there. They don't have to like close the patient, finish the surgery, then later on, afterwards, they are told, it's not, the sample you took was not adequate, was non-diagnostic. There are no adequate cells. So intraoperative diagnosis will help avoid a secondary surgery. We'll be able to help the surgeon sample adequate sample. Another thing is the sample, maybe the biopsy, they are trying to assess the margins. They'll be able to see if the margins are positive for tumor or negative. If the margins are positive for tumor, it will guide them to sample adequate sample of tissue. Then intraoperative diagnosis will also help determine if the lesion is benign or malignant. Just the patient is still on the table, the pathologist is able to examine the slides, whether it's an FNA or it's a biopsy, and will be able to tell this sample is malignant or this sample is benign. We all know that when you have a lesion, when anyone having a lesion and it's processed and the results say that it's benign, it's always good news for the patient and also to the relatives and to the clinical team. If it's malignant, then the surgeons will be knowing what to do immediately after the surgery. They'll even if they wait for the other results, further results, they'll be having an idea on how to start planning for the treatment plan. So when you're talking about intraoperative diagnosis, what kind of samples, specifically in histology, are we looking at? We have the imprint smears, we have the scrap smears, we have the FNAs, and we have the frozen sections. All these can be taken and processed in a histology laboratory. So let's look at the imprint smears or the touch smears. What is an imprint smear? An imprint smear is just, you have, when the surgery is going on, you just take a tissue is just taken. You can see this is just a biopsy right here. This is just a tissue that's been just sampled. Then you smear it on the slide. You just make a smear on the slide, or you touch the slide. That's why they're also known as touch. You touch on the slide, then you prepare a smear, and this smear is then fixed and stained using the quick staining technique. That is the deep quick staining technique. That is the mostly used technique for intraoperative diagnosis. Then you stain it and it's examined and you get your results. So imprint smears, these are valuable tool in intraoperative diagnosis because it yields rapid and relatively inexpensive. It's rapid and relatively inexpensive method. You can see it's very rapid and it's not expensive because this one can even be done in areas whereby we call it resource limited areas, whereby you don't need to have those complex machines like the cryostat. You just stain. So long as you have the stains and you have a pathologist, they'll be able to stain and then examine. The results for imprint smears are usually out, or should be usually out within 5 minutes. And then the imprint smears preserve cellular details well. It's cost effective because it doesn't consume anything apart from the slide and the stains. And then there's minimal tissue handling. The moment you take your tissue, you can see this blade is here. It was used to excise the tissue. The moment you take the tissue is excised, then you make the smear on the slide. You're done with that tissue handling. Unless you will need to do further the routine histology, whereby you need to stain to fix the tissue, allow the tissue to fix, then you process it using the routine histological tissue processing. So where do we apply imprint smears? If they are very important in margin assessment, they are also very important in difficult cases, the cases whereby you've taken a frozen section and your results are not like so conclusive, you can go back and just do an imprint smear and then compare the results. Then it's also the imprint smears are important in lymphoma diagnosis. Those are just tumors of the lymphatic systems. The system, then they are very resourceful in resource limited settings. Just like any other method, the imprint smears will have their own disadvantages or limitations. Of course, they're not suitable for all cases. And then they require some level of expertise. Even the pathologists should have done this one for quite some time for them to be able to produce reliable results. And then in most cases, a combined approach is needed. And this combined approach, when you're talking about intraoperative diagnosis, we are talking about a combined approach of both imprint smears and frozen section. So if you are in a resource limited area, you'll not be able to combine the two. Like you'll not be able to do a frozen section. You'll just have to rely on the imprint smears alone. Another sample that can be processed intraoperatively is FNF fine needle aspirations. This one, we are just using a fine needle to collect cells from a mass or from a lesion. And the FNA is used to prepare a smear. And the material collected are used to prepare a smear on a slide. And it's also stained using the quick or the rapid diff-quick method. So FNAs provides a less and inexpensive, rapid, and cost-effective diagnosis during surgery. A fine needle is used to aspirate cells. As you can see here, the fine needle is being used to aspirate the cells of the sample. It's used to aspirate cells from a suspicious area. Then the cells are stained using the diff-quick staining technique and then examined. And the report is released on site. Application, it's very resourceful or useful in lymph node assessment for METs. When you're talking about malignant tumors, there's always an issue of metastasis. So when you want to know if this, like maybe a client is having a breast lesion or a breast cancer, and you want to see if this cancer is spreading, you might need to assess some lymph nodes. So this one will just help you to collect the sample from the lymph nodes and to know whether the tumor is spreading or not. It's also very useful in thyroid nodules. We all know where the thyroid is. So reaching there with a needle is always easier. Just collect the samples and then the cells, and then you prepare your smear and you process it using the diff-quick. We shall see the procedure for diff-quick just in a few. Then it's also important in lung nodules, and then breast lesions. You'll notice I've not talked about the scrape smears, because the scrape smears are not so different from the FNAs and imprint smears, the handling, only that you have to use a sharp object like a blade to scrape some tissue, some material from a fresh tissue. Then the material that you have scraped will be used to prepare a smear on the slide, and then you process it just like an FNA or an imprint smear. So when you're talking about the diff-quick staining method, it's very rapid, and we normally use the field stains. I know most of us, when you are training or maybe in your station of work, you've come across the field stain. I remember it was when I was training, you were told that it's used to stain malaria parasites. But now, when you're using this one in histology for the diff-quick staining method, we do the reverse of the field stain. You remember the field stain A is the one that looks dark blue. Then the field stain B is the one that looks like it's the orange color. When you're staining histological smears or cytological smears, the imprint smears, we do the reverse of the field stain. So our solution one field stain B becomes our solution 1. Then field stain A becomes our solution 2. Then after you prepare a slide, you'll have to fix the slide. And the fixative used here is usually methanol. You fix your slide with methanol. Then after fixing, you stain in solution 1, which is field stain B, for just 10 to 15 seconds. You can see the staining period. Then you rinse. After rinsing, you will stain in solution 2, which is field stain A, for again around 10 to 15 seconds. Then after that, you just rinse in distilled water and air dry and examine. It's not so complicated. You can see this procedure, if you look at it, it takes less than 2 minutes. So that is applicable intraoperatively. So all those, the FNAs, the imprint smears, the scrape smears, when you do them and you want to release results intraoperatively, this is the best staining technique. You do the diff quick staining method. Then we go to the frozen section. What's a frozen section? This is just a biopsy that is taken and it's processed when it's still fresh. You just take the biopsy. Then after it's taken, you don't fix it like the routine histology. For the routine histology, the biopsy is processed when it's still fresh. So handling is very important. PPEs, always make sure that the correct PPEs are done because you are handling a fresh sample. So once it's taken, it's just delivered to the lab, and then the grossing is done, the areas of interest are sampled, and then you will embed this particular biopsy in the OCT gel. OCT gel is the embedding medium for used for cryostat when you are using the cryostat. So you'll just embed this one in the OCT gel. Then after that, you put it in there. The cryostat has a freezing chamber. It will freeze and form a block, and that block is cut, sectioned just the normal way. And then it's stained and examined. So frozen section, these are rapid diagnostic tests using during surgery to help guide the surgeon's decisions. It involves quickly freezing a fresh tissue, cutting it into thin slices and examining it under a microscope. Frozen section can also be used in immunocytochemistry and immunofluorescence. So why frozen section? Frozen sections will yield real-time diagnosis. They are very important because they guide surgical decisions. For margin assessments, like I said before, margin assessment will be able to tell which margin is positive or which margin is involved with tumor. So what normally happens when the surgeons are remove the samples, the biopsy, the frozen section, and they want this pathologist to assess the margins. If the margins are either positive or negative for tumor, they normally mark the margins using sutures. They'll mark a margin like this, say, like they'll use a short suture. They tell you the short suture is the posterior margin, the short one or the long one is the inferior margin, 2 sutures, the superior margin, 3 sutures, the medial margin, 4 sutures or no suture is the lateral margin, the deep margin. They'll mark all those margins, and then they'll write the notes on the request forms. So when you are cutting, when you're examining, you'll be able to tell, I'm examining the posterior margin and it's free of tumor or it's involved with tumor. I'm examining the lateral margin or the superior margin or the inferior margin, and you'll be able to tell whether they are involved or not involved. Then frozen section will also assess for lymph node involvement. Lymph node involvement, you'll just know if it's normally to tell whether the tumor is spreading. Then frozen sections are very important because they help avoid a secondary surgery. They'll be able to guide the surgeons and tell them that they have removed the entire tumor. And if they have not, like if you tell them this margin is positive. That means that area is involved. So they need to sample adequately to remove, to make sure they have removed the entire tumor. So when you are talking or thinking of a frozen section, what should be the consideration? What do you need to consider first? The availability of the surgical team. The surgical team, that is the surgeons, the anesthetist, the theater nurse, the porter who will be able to deliver the sample. The pathologist should be available and notified in advance. The technologist should be available and notified in advance. Then the cryostat machine should be available. You cannot do a frozen section if you don't have a cryostat machine. So you should consider the availability of all this and communication in advance. When you're communicating in advance, this will help the laboratory, the histology, the pathology team to prepare. Because you cannot tell a pathologist we have a frozen section and you had not communicated in advance. Maybe this pathologist is in the middle of a postmortem. He will not be able to leave the procedure and come start reporting a frozen section. So a communication has to be made in advance. When you communicate in advance, you will help the technical team in the histology laboratory to prepare. And part of the preparation is to switch on the cryostat machine. Because this cryostat machine has a freezing chamber that it should be at a certain temperature, should be set at a certain temperature. It should be operated at a certain temperature, like it's -20 to -30. So you have to switch the machine on in advance so that the temperature, the machine can acclimatize the temperature. Then when you're communicating, when the surgeons are communicating, they should be able to tell the pathologist what they need to know. A brief history of the patient, clinical diagnosis, what they think the patient is having, what they're interested in, the radiological findings, what the surgeon needs to know, what they have sent. If you have sent a lymph node, tell us you've sent a lymph node. If you've sent the margins, tell us I've sent the margins. If you've sent whichever sample that you're sending, then you contact and then how to contact the surgical team. Once the report is out, how are you going to contact the surgical team? How are you going to deliver the results? Are we going to do a handwritten report and then give to the porter, or are you going to communicate by mobile? You should consider all those. Preparation. How do you prepare for a frozen section? This is just a theater setup. So how do you prepare for a frozen section? The theater team prepares for surgery. Preparation means even booking the theater, preparing the patient in advance, because we all know if a patient has to go for surgery and the patient has eaten, they'll not proceed with the surgery. So the patient has to be prepared, has to fast for some hours, like 6 hours before the procedure. The surgical team will then communicate to the pathologist or the laboratory and tell them, we are planning to start our procedure at 10, so please prepare adequately. Then the laboratory people will be able to prepare by switching on the machine, setting up the staining area, the fixatives required, making sure the OCT gel is in place, everything that they need, so that when the sample comes, they start. Then the porter should be on standby, because this sample is going to be delivered immediately, whether it's within the institution or from outside. If the communication has to be done in advance and the sample porter has to be on standby, the sample should be delivered immediately, preferably within 15 minutes. Then the client is given anesthesia once they're ready, and the surgical procedure begins. When it starts, once they have opened the patient, the areas of interest are sampled, and the sample is then promptly delivered to the lab by the porter who was on standby. So what I'm having here is a picture of a cryostat. This is what we call a cryostat machine. This is just a microtome, like a rotary microtome inside this. It's that it has been incorporated by a freezing chamber. Cryostat. So cryostat is a specialized instrument that combines a microtome with a freezing unit, preserves the delicate structures of the tissue, and it's very useful in rapid diagnostic and in research applications. This is a cryostat. You can see this like inside here, this is a microtome. This is the handle. That's just like the normal handle for the rotary microtome. Then this is the switch that once you connect to the power, you will be able to switch on here, and you will be able to see the temperatures here. Once you set the temperature here, then this is the lid. This is a lid. It opens back and front. When you push backwards, it opens, and you are able to access the microtome inside here and the freezing chamber. Then down here, sorry, my stool is obscuring, is a bottle. There's a bottle here for the waste bottle is there. The waste container is there. So this is how the microtome looks, the cryostat looks inside. You can see this is just the microtome here, just a microtome. You have the anti-roll plate here. You can see this is the blade. The blade is here, the normal microtome blade. Then we have the block holder is here. Sorry. The block holder is here. Is holding a block. This one is the freezing unit here, the freezing chamber. This is the freezing chamber. Once the temperatures are very low, -20 to -30. Then once you put your tissue, once you put your tissue on the tissue holder, there's a tissue holder here. Then you put the OCT gel. The OCT gel is the embedding medium that is used to embed tissues for this cryostat. Frozen sections. OCT simply means optimum cutting temperature. So it's called an OCT gel. It's just a gel, and it's just as clear as DPX, just looks like a DPX. It's normally in a plastic container. So once you put your tissue on the tissue holder, you are able to dispense your OCT gel or the embedding gel. Then after that, you put your tissues here. They call it tissue shelf. When you put it here, they'll start freezing. Once they freeze, they form a block, and you are able to put your block here and just cut. During cutting, ensure that the cryostat is locked. Just lock it using the lid. This lid here. Make sure that you lock it. So when you're cutting from inside, just place the block here. After placing a block, you lock the cryostat for safety purposes, because you're handling very fresh samples and you need to prioritize your health. So make sure the lid is locked. And then another thing is to optimize the temperature inside, because when you open, you're allowing air to go inside. You're allowing moisture to go inside. So this is just like the inside of a cryostat. This is how it looks like. So this is just the summary of how the frozen section is handled. Sample, once it's received in the lab, the sample identification and accessioning. We should make sure that the sample is well labeled and it has a request form. And the request form is agreeing with the sample, the details on the sample container. Then it's received and accessioned. Just given a lab number. Then the pathologist who is ready does the trimming or grossing, sampling the areas of interest as requested by the surgical team. Then you embed the tissues in the embedding medium. That is the OCT gel. Then you freeze in the freezing chamber of the cryostat, as you have seen. Then you will stain the tissues using the quick H&E staining technique. For frozen section, the quick H&E staining technique is preferred, but you can also do the if quick, but normally for structural, because we want to see, remember for cytology, you are interested in the cells. For histology, you are interested in even the structure, the tissue itself, like the entire tissue, the structure and everything. So you are supposed to do the routine H&E, but now you'll use the quick H&E staining technique. You section, then you stain. This is just a demonstration of how you remove of how you collect the sections when you're doing sectioning on a cryostat. Sorry. Once you section, you touch the slide. This ones, you remember this just like water. The gel has frozen. So when you touch the slide, the gel or the embedding medium is able to melt off. And then you remain with the tissue alone on the slide. Because the tissue will be able to attach to the slide. It just like sticks to the slide. Then the medium, the embedding medium melts off because the slide is warm and the tissue is frozen. So when you touch the slide to collect the tissues, it will be able to melt off. The embedding medium will be able to melt off. Then you just remain with the tissue. So you touch the section by slide, and then the section will be able to float to the slide. When you're doing this, kindly avoid stretching or folding of the section during this process because they are very delicate. They are very delicate. Because you remember when you're doing the routine histology, there's a process called infiltration. And infiltration is meant to give the tissue internal support. For these ones, there's no that process, just embed directly. So they are very delicate. You have to handle them with care. So just the staining technique that is used to stain frozen section. Remember, the procedure should be quick. So you're not going to do the routine H&E. You're going to do the rapid H&E technique. And the rapid H&E, once the sections are on the slide, they're fixed in 95% alcohol. Then after just 10 dips, 95% alcohol. Then from there, you further fix in formalin, like 10 dips. Then from there, you'll rinse in distilled water. After rinsing in distilled water, stain 10 dips again, stain in Harris hematoxylin for 30 seconds. After that, you rinse, then again, 95% alcohol, 10 dips, just to ensure that the cells do not wash off. Then you counter stain in eosine yellow for 15 seconds. Dehydrate ascending grades of alcohol. Then you mount from DPX. The time you use in eosine should be half of what you stained in hematoxylin. So if you're doing 30 seconds in hematoxylin, do 15 seconds in eosine. If your stains are weak, you can do like 1 minute in hematoxylin, then 30 seconds in eosine. So after you stain your slides, the slides are then examined. There's no even room for you to allow the slides to, like, you allow the slides to set or what. Immediately you are done with mounting, the pathologist should be able to examine the slides. Then the results are communicated to the theater team. Can be done verbally. A written report is then done and then dispatched. The remaining biopsy, you don't throw it away. It's fixed. You put in formalin, fix and process routinely, the normal routine way, the way histology samples are normally processed. So what are some of the considerations you have to consider when you're staining using the rapid H&E? Time sensitivity. The whole procedure should be done within 3 to 5 minutes. So do not overstain the samples. The patient is on the table, is waiting for this particular results. So try to minimize time. Then another thing, when you're using frozen sections, there's the artifacts. You have to go artifact minimization. There's a tendency of frozen section having artifacts, like attracting artifacts, because when you're sectioning, it is advised that at all means you avoid thawing the sample. That's why I even said when you are sectioning, make sure the cryostat remains closed. If you thaw, you freeze and thaw, that ice crystals might attract artifacts which might be seen on stained slides. Then quality control. For quick H&E staining technique, you can compare the results to the routine H&E results. Once you are done with the results and communicated to the theater team, the remaining sample is normally fixed and processed the normal way, the routine way. And once the results are out, you can compare with what was reported. Diagnostic accuracy. Frozen sections are reliable, but less sensitive than the routine H&E. When you're doing the routine H&E, you'll find that they're sensitive. Yes, the sensitivity is about, for frozen things, about 90%, specificity is about 95%, but they're less sensitive than the routine H&E. Then consider alternative available methods that are available commercially. Like maybe if you're having commercial stains, consider using them rather than preparing your own stains. How do you handle cryostats after use? As I mentioned earlier, PPE. Kindly don the correct PPE because your safety comes first. You are handling a fresh sample, and this one must be handled with a lot of care. So make sure you don the correct PPEs. Make sure you're having gloves. If possible, you can use the surgical gloves. Then make sure even when you're cutting, you take care of the knives. Those knives that you use for sectioning, make sure you dispose them well. Used blade should be removed and disposed in the sharps container immediately. And when you're removing the used blade, do it with care. Then the chamber cleaning. Make sure you clean the chamber well using gauze, clean gauze. You used to clean the chamber. Then after cleaning, you can disinfect. The chamber is normally disinfected using 70% alcohol or 10% bleach. You can use either. Those 70% ethyl alcohol is adequate. If there's provision for UV lighting, you can leave it on for some time for sterilization. So what are some of the disadvantages of frozen sections? They're not as detailed as traditional histology, of course. Then there are potential for diagnostic errors. Yeah, you can miss, it's possible, it's true, you can miss some tumors. Then technical limitations affect the accuracy. And here we are talking about the technical limitations. We are talking about what the technical team is able to do on a frozen section. You see some tissues, some lesions will need additional stains, like the special stains, like the ZNs, GEMSA, but you're not able to do that on frozen sections. So that one limits their accuracy. You'll not be able to give the correct diagnosis. Then there's introduction of artifacts, especially during freezing. I think I mentioned that because of the freezing and thawing. Then storage challenges. Storage challenges meaning the sample, once it's removed, just have to be processed like immediately. And then the remaining sample, you cannot unless you are going to keep it on liquid nitrogen. But If you don't have that, you'll not be able to keep the remaining sample. So you'll just have to process the remaining sample using the routine histology methods. Thank you. And that is the end of the presentation.
Thank you very much, Christine, for the great and knowledgeable presentation on histopathology. It's one of the units or the subjects that most of us laboratory scientists will shy away from. Thank you for tackling it so well and educating us and enlightening us on tissue and especially the frozen section. So I would want us to tackle the questions that are streaming in. The first one that I would want you to tackle is Philip. This is not a question, but just Philip Songol saying it's a great presentation. And the first question comes from Hilary Toom. Hilary Toom says, hi, is there a way of preventing ice crystals, artifacts in cryo section or frozen section? Christine, I think we'll tackle that as we get more questions coming in.
Yeah. Yes. As I had mentioned, if you want to minimize ice crystal-like artifacts, make sure you don't store the samples. Once they are frozen, make sure that they are cut frozen. And that's why I insisted that the lid on the cryostat has to be kept like closed for you to avoid the thawing of the samples, because if you freeze and thaw, that's when you attract the ice crystals, which presents as artifacts. So avoid thawing the samples.
Thank you for that. I hope, Hilary, you've been answered. The next question comes from Alfred Kipkirui. Alfred Kipkirui asks, what is OCT in full, kindly? What is OCT?
Optimum cutting temperature. Optimum cutting temperature compound. That's the gel that we normally use when we are doing frozen sections on a cryostat. It's the bedding medium. Yeah.
Thank you. Next question from Emmanuel Baraza. What are the stains used in DIFQuick? What are the stains used in DIFQuick?
Let me just take him to the slide. Sorry. I mentioned we are using the reverse of field stain. Yeah. The reverse of field stain, we have field stain A, which is now our solution 2, and field stain B, which is normally our solution 1. So it's just a reverse of the field stain. Yeah.
Okay.
Nelly, back to you.
Thank you for that. Thank you, Christine. Abdul Fatah Abdullahi asked, he starts by greeting you, hello, asking about quick field staining. I guess this is DIFQuick.
Yes.
Staining technique on tissues. For me, what I know was about only PBF. Please elaborate more about principles. I think the principles, elaborate about the principles of DIFQuick in tissue staining. Christine, back to you.
Sorry, I take a glass of water.
Oh, okay.
Principle for DIFQuick in tissue staining. For this one, DIFQuick utilizes two field stains. That's field stain A, field stain B. Our field stain A becomes now our solution 2, and field stain B becomes our solution. Our field stain B becomes our solution 1. That's the orange one. So we use this one. It's just like it stains the cells, not in tissue. Mostly it stains the cells. But now, one stain is able to pick the nucleus. Of course, the nucleus will pick solution 2, which is that film stain A, and then the background picking the solution 1. Just that basically. Hope it helps.
Yeah, yes. A question, and this one I'm picking it from the chat section. George Luquiso asked, what advises the choice between doing the touch prints versus frozen sections? What advises the choice
I got
between...
it. Yeah, I got it.
Okay.
The touch, that's the smear technique, touch smear. I mentioned, especially when it's it's resource limited area 1, whereby you don't have the cryostat, and then the availability of, because for the touch mostly it's results on site. Like you can we normally do a setup in the theater, like just a place is given in the theater, and then the results are just, you stay in it, then the smear is made, then the pathologist is there reporting, and you have your results. So that one is very resourceful in results on site. For the frozen section, you see you have to ferry this sample to the lab where the cryostat is. Then another thing that will advise the choice is the mass that you're looking at. If it's just a place that you can attach the slide, like it's maybe it's just like the mass, the lesion is not deeply rooted. You don't have to go for a smear technique. Like, no, for the frozen section, you'll just do a touch. And then another thing that will guide is what you are looking for, because the smear technique has its own limitations. It will not be able to give you the entire, it's not a representative of the entire section, because you see for the frozen section, you are cutting the sections, the tissue is embedded, then you're cutting the sections. So you have a view of both the outside and the inner of the lesion. Yeah. So whatever the surgeon needs to know will guide, but you can still do, I said a combination of 2 will always be recommended.
Thank you, Christine, for answering that. Another question from Caroline Rinya. Caroline asks, kindly confirm if we do rinse after field stain B before going to field stain A. Yeah,
kindly rinse, because you will keep on, like, you will be transferring field stain. You'll be transferring solution 1 to solution 2. So you rinse.
Thank you for that. Benedict Wachala says it's a nice presentation, and I concur with him. My question is that if maybe someone has malignant tumor, and for an error you report it as benign tumor, how do you eliminate such errors?
Routine histology will help, because I've said once you are done with the frozen section, there's that remaining biopsy. You process it routinely, then you do the routine histology, and you'll be able to tell. Though it's very rare for you to see for you to say a malignant is benign.
Okay. Next question is Collins Muleshe. Collins asked, how do you validate the report, or what are the QC procedures that are taken?
Comparable to routine histology. I think I mentioned somewhere. Once you've reported your results, the remaining biopsy, will process it using the routine histology, then you compare the 2. But for frozen section, you'll just have to release the results that you've seen there, and then you'll wait for the routine histology to be out, then you'll be able to compare the 2.
Okay. Okay, thank you. Victor Kibet, next question comes from Victor Kibet, and Victor Kibet says, this is a great presentation. Considering intraoperative procedures are sensitive, what is your quality perspective on these to minimize risks that may occur?
Risk that may occur to the lab person.
Yes.
I've insisted on using the correct PPEs and just following the standard operating procedure. Like, you do not like start handling the knives that have been used to cut frozen section with bare hands. Just make sure you follow the procedure, you do the right thing. PPEs are very important because you're handling fresh samples, so your safety should be a priority.
Thank you, Christine. Elias Elukol just wants to confirm, do we use normal running tap water or distilled water after solution A and B? That is after when you want to wash from solution A going to solution B.
From my screen, from what is in the screen, you can see we are using distilled water. But if you don't have distilled water, don't kill yourself. You can use normal water.
That's noted. Kevin Osundwa, there are some manufacturers who produce their own procedure and there is no rinsing, or is it a must?
Okay, if a manufacturer, my take is, if a manufacturer has, like, you know, when you buy a kit, you normally, there's always a deviation in even the timings, even the normal histology, like the H&E techniques, there's always a deviation in the timings. So if a manufacturer says, do this for 5 minutes, do this for 8 minutes, kindly follow that procedure. What I'm giving you here is what is in the books. But now, if a manufacturer says you stay in solution 1 for 2 minutes or for 1 minute, I saw someone doing solution 1, 30 seconds, solution 2, 30 seconds, someone does 1 minute, solution 1, follow the manufacturer's instruction. You normally say follow the manufacturer's instruction, because I won't be the manufacturer. I cannot dictate what they have prepared. So that's my take.
Thank you, Christine. Alvin Kinji asked, is H&E staining techniques applicable for staining tissues when TB is suspected?
TB, you normally go for ZN, and if you don't have the ZN, you can do FITE. You have the FITE Farako staining technique and the ZN. So those are for TB. Because FITE Farako is for bacilli. It's normally it's preferred for leprosy, but basically it's able to pick bacilli because the leprosy is bacilli. So for TB, ZN. If you don't have ZN, do FITE. If you don't have FITE, do ZN. Not H&E. H&E will not be able to pick TB because, one, even the counter staining, the routine H&E is pinkish in color. So what does that tell you? We know that bacilli is pinkish. So the counter stain is pinkish. You'll not be able to pick the bacilli. So routine for ZN, for TB, ZN. If not ZN, do FITE Farako staining technique.
Thank you. Thank you, Alfred Kipkirui, and asked a question. And thank you to Edina Ombiro, who answered the question for him. Maybe I'll just read it for our presenters to note. Can decalcification applies in all histological techniques? And Edna answered and said, no, it's done only on calcified tissue. Edna, you are right. And Alfred, I hope you noted that. Next question comes from James Ireri. James says, hello, and kindly, I've seen the hands that are raised. I will be coming to you. Don't tire. I will come to you. Let me just finish the questions on the chat, and then I'm coming to the people that have raised their hands. I'll give you an opportunity to ask your questions. So James Ireri says, hello, besides preparing the slides and staining, how far do you go with reporting? With an MSc, can one make an interpretation?
For cytology, yes. For histology, no. The training doesn't allow. Sorry. That one you leave it for the pathologist.
Thank you. You ready? I hope you answered. Kennedy Peter Matunda. Oh, this is just a comment. He says, a good presentation. Have learned a lot. That's Kennedy Matunda. Let me just check if, and then there's Kevin Osundwa. Once you have a tissue, at what point do you prefer performing deep quick when the common recommended processing is H&E as per the pathologist?
Deep quick, you said it's for mostly it's for cytological smears, though when you do deep quick for histology, that is for frozen section, it's normally to assess maybe the diagnostic adequacy. But for reporting, I said we do the rapid H&E. Yeah.
Well noted, Christine. Now I'm here at participants who've raised their hands. I will start with John Wahome. John, I will allow you to speak so that you can pass your message.
Yes, good evening, Daktari.
Good evening, John.
Yes, I like your presentation. Huh?
Thank you so much.
Very clear and on point. Huh?
My
question is on quick dip. Huh?
Quick diff.
Yes. Yeah. You know, on reverse in parasitology, we prepare a thin film for reverse.
Yes.
Either it is for malaria. In your cytology and the reverse, do you make a thin film or a thick film? Or how do you prepare it? You know.
Okay, let me ask, how do you prepare your thin films and your thin and thick films in parasitology?
In parasitology, you know, you use the angle, didn't film use it. We make a tail smear.
Yes.
You put a very small drop, then you know, you slash with another slide to make a thin film.
Yes.
Then you fix with the melanoma, of course. Then you reverse stain for specifications, either for plasmodiums.
Yes. That's
now
exactly how you prepare it.
No, sorry?
That's how exactly you prepare it. You put a drop of the cells.
Now you are histology now.
Uh-huh.
How do you go about it anyway? Is it a thin or a thick film?
Thin.
Still thin?
Yes.
You make like that one of
yes.
a malaria parasite or?
Yes. The way we prepare just slides for FNAs. Just putting a drop. But you know mine are cells, most of their cells.
Yes, true.
Then you use another slide, then you like squash.
Okay.
Yes.
So okay, right. Point taken. Thank you a lot.
Welcome.
This one is not a question as per se, but a statement. You know, the histology is one of the best subjects, yes. But the problem I get it with is, you always do for pathologists, but not you doing the reporting side of it. You know, that one gives a lot of discouragement on pursuing that line of it.
I know, but
because you will always, you know, you will always prepare, do all
very good slides.
Huh?
I get you.
Yes, that is the headache we get on it because you know. Yes, we wanted to also to be on that place making right decision at the end of the report, but you know.
Allow me not to go that side, but that line. Allow me.
Okay, I understand.
Allow me not to comment to that because I think it's even the training. It's limited to that, but let that not limit you, because it's not all about reporting. Okay, I can report cytology slides. You can report cytology slides. Yes. That one you are given the leeway to report. But when it comes to histology, I think the pathologists have owned it. Pathologists have owned it. So let me not go that route.
Okay, Doc. Appreciate it.
You're welcome.
Thank you, John. Thank you, John, for your contribution. The leadership of LMSK are here and they've had you clear. Next person that I would want to allow to speak is Mwita Matiko, kindly. Mwita?
Yes.
Your question?
Yes, can you hear?
We can hear you. We can hear you.
Okay, thank you to my learned colleague. My question is, can this procedure be done from theater?
For Rose, results on site. For the diff quick, yes, we do it. We do it there. For the frozen section, we normally do it from the lab, mostly because okay, you have to get a space in theater, you carry your cryostat to theater and all that. So if your theater setup has that provision that the cryostat has to be there, and you can go and do it from there. But we normally do it from site. That's why I said from the lab. That's why I said you have to have a porter that is standby. But for the rows, the cytological techniques, the results on site, you just do it there. Or the only equipment you'll need to carry with you is a microscope. Then you just stay and your stays. Yeah.
Okay, thank you.
You're welcome.
Thank you, Mwita. Next was Alvin. Alvin, I'm allowing you to ask your question now.
Hello?
Yes, we can hear you.
And how are you?
Fine, Alvin.
This is a very nice presentation, Daktari.
Asante, thank you.
Here, an area in histology and cytology is quite complex.
Not really.
And maybe my simple question would be, apart from the microtome, which I've seen there, and the H&D stains, is this department, do we have fully automation in this line of specialization?
Would you kindly visit Kenyatta National Hospital one of these fine days, and you see the magic behind histology? Yeah, we have automation. We have the grossing chambers are there, with even which are even able to release the fumes, the formalin fumes when you're grossing. Then you no longer stain manually. We have the automated processors, tissue processors. We have this automated we have the auto stainers, cover slippers. We have robots in the lab.
Okay.
So if you happen to be anywhere close to Kenyatta National Hospital, just come and take you through so that you can appreciate the digital. We are almost going to digital pathology.
I can come, Christine. Actually, your voice I'm very familiar with your voice.
Oh, really?
I don't know where we have never worked with you somewhere. But maybe my next question would be,
okay. We
usually get pathologist reports showing that the tissue had TB. The acid fast bacilli.
Yes.
And you just answered my first question about them using Zden. If that is the case, why don't we just use the same Zden we use for sputum on tissues? to detect TB in our normal labs without passing through the pathology department?
Do you have histology set up whereby the tissues will be processed?
Or it must be processed first?
Yes, that's why I said one of the limitations for frozen sections is the technical limitations, because you're not able to do special stains like Zeden. I mentioned that. Yeah. If you process, you are able to, and you do your sections, you stain using, you stain the den. You just stain, then you are able to examine. Once you pass by, I'll be able to show you. I have positive the den slides and blocks. I'll be able to share with you.
Kenyatta, I can visit anytime, Madam Christine.
Karibu.
Yeah, thank you.
Okay.
And maybe my third question and the last one, we who work in the hospital, we get confused when the doctor requests for tissue gene expert. So now we wonder, how do we examine or assay a tissue using gene expert, yet tissues are just particulate? Is it the recommended request from the doctor, or they are off the line?
If it's a tissue.
Yes, the request for gene expert tissue.
Okay, even the machines you're having in KNH, it's normally does a gene expert on fluids,
All right.
or FNAs. But when it's a tissue, there's a day I was trying to tell my colleague, why don't you crush the tissue? It becomes
What is the working principle?
I understand the process. I understand the principle behind the machine for gene expert. So
yeah, but
do you end up doing the gene expert on tissues?
That's now the confusion. At times we end up consulting widely.
Because what should be done, it should be TB PCR for tissues. Tissues should be TB PCR. Because unless, I've not heard of it, but unless there's a machine for doing gene expert on tissues, because the machine that I know that is available in most of the setup is for fluids and fluids, right? So mostly, I think when they request for gene expert on tissues, I think the most appropriate test should be TB PCR. Yeah.
Yes. So in case a doctor requests for a tissue analysis for gene expert, would you
do
telling us PCR, that one?
Yes. Yeah.
It's appropriate for us to advise them. We take the sample to the pathologist to do the then on using the normal histology analysis.
Yeah, the then can be done. And if by any chance you have fight, I know most people don't do fight. You do fight? Fight Farako staining technique?
No.
Yeah, that's another test that can be done, and it's actually more sensitive. It's more sensitive than the routine Zeden.
Thank you, Daktari. Thank you.
You can find more. You can just try to get more information about fight Farako staining technique.
Thank you, Doc. Thank you.
You're welcome.
Maybe you could have shared with us your number.
My number.
The consultant. In that line.
Nelly, kindly you share my number.
Kindly, they're interested. We want to be consulting you in that line, Daktari.
Alvin, for your contribution. Thank you for your contribution, Alvin. Christine, I would like Derek Kiptum to ask his question. And there's one more question we will take after Derek. Derek, can you speak now?
He's muted.
Can you unmute, Derek?
Good evening.
Good evening, Kiptum.
Yes, Derek, we can hear you. Derek, can you unmute kindly? You can unmute and speak. Okay, I will allow Abdi Fatah. Abdi Fatah. Abdi.
Hello.
Hello, Abdi. Yes.
Yeah, you're hearing me. I'm asking the doctor.
Hi, Abdi.
About histology and cytology, what I've been trained under my training, under my course study, what I know was about tissue processing, microtomy. Then after microtomy, it was about fishing. Then preparation on slide. After preparation on slide, the tissues we used to stain H&E. And in the term of cytology, was about like FNA used to stain and perpendicular stain. Then the pathologist used to study under microscope. Then he writes on report. I want to ask the doctor about the part of quick field staining, where she said it is reverse staining. I wanted the doctor to elaborate for me, because what I know about that reverse staining of field stain, where you start field 2, then you go to first you fix, then field 2, then field A, was about only BBF. I wanted to know, well, will it still remain under Romanowski principle, or about what? I've never heard about that. I wanted just to gain more about that on from the doctor. Yeah, thank you.
Quick diff update. Quick diff, we said it's used it's the reverse of field stain, and it's used to stain mostly cytological cells, and it will be able to you'll be able to assess like many cytological smears and FNAs when you need results on site, quick results. You're not going to do the routine H&E. And this one, mostly, it's just to guide the surgeon's like decision. It's not for quick diff in cytology, mostly it's not for diagnosis. It's just for guidance. And guidance will just make you, it will just tell the surgeon, you have sampled adequate tissue, like the FNA is adequate, because we'll realize most of the FNAs, especially for thyroid nodules, will get the results saying that in a diagnostic material, unsatisfactory specimen. So you'll be able, the main reason or the main aim for results on site is for you to get enough, to be able to get, like to assess the specimen adequacy. And you'll be able to tell whether the cells you have harvested, whether they are benign or they are malignant. So it's for quick diagnosis. That is why it's intraoperative diagnosis. Okay, to assess to assess the adequacy, specimen adequacy, and then for rapid diagnosis, like just telling you there, it's benign or malignant, but not the exact condition. You can say it's malignant, but the exact, if it's a breast, like let's say that, like for example, it's a breast FNA, you do the diff quick, you will be able to see ductal cells that are malignant. Like you say, these cells are not normal, they don't look benign, they are malignant. You'll tell the surgeon the cells are malignant, but you'll not be able to tell the surgeon which type of cancer it is, whether it's invasive, whether it's in situ, whether it's medullary, whether it's lobular, okay? Just for like guidance. Yeah. Hope it helps.
Thank you, Christine. Abdi Fatah, I hope it helps. And Next person is Abdi Hassan. Abdi Hassan, make it quick, kindly. Can unmute now, Abdi. Abdi Hassan. Abdi Hassan, are you there? Okay. Abdi, it seems you're not getting Abdi through. Muita, is your hand raised for another question or Muita?
Yes.
Did you raise your hand again?
Can you get me?
Yes, we can get you.
Yeah. Maybe my question is, can chemistry work for this instead of this quick test? Hello?
I didn't get that, Nelly.
He's asking, can
Hello?
histochemistry work instead of DiffQuick?
Histochemistry, immunohistochemistry.
Hmm.
You will not be able to do immunohistochemistry
Yes,
on
yes.
immunohistochemistry.
Yeah,
Yes,
that's
Yes. No, you'll not be able to do immunohistochemistry for assessing for intraoperative diagnosis, because even the procedure for immunohistochemistry is way long than even the routine H&E staining technique. And then if you're asking if we can do immunohistochemistry on frozen sections, no, we can't, because the samples have to really fix well. The processing has to be well, because the antigen retrieval in the antigen retrieval in the whether it's manual or in the machine using the immunohistochemistry machine, that's the Ventana machine or whichever machine that are being used, the temperatures are normally very high. So if the samples are not well processed and fixed well, they'll be able to wash off. So you'll not be able to stain anything. Hope I've answered you.
Thank you, Christine. Finally, I think this is the last person I'm giving an opportunity to ask a question. Stephen Muredi, kindly unmute and ask your question.
Yes, hello everyone.
Hi, Stephen.
Yes, I was asking, here the machine, Christostat, the one which cryostat. Yeah, the one which is used for frozen sections. When you are presenting the presentation, you are saying that it is supposed to stay at optimum temperatures. I wanted to understand the optimum temperatures of that cryostat. Is it the normal body temperature, that is at 7 degrees, or because it is dealing with frozen the temperature?
No, I said when I said first the theater team will have to communicate in advance to the lab team, and the lab technologists will be able to switch on the machine so that it can acquire the optimum temperature for sectioning a frozen section. And the optimum temperature, I said, is between -20 to -30. So for it to get to that temperature, you see, it's like it has to go slowly, like it has to acclimatize slowly. So you have to switch on earlier before the frozen section is there. And then during operation, I said, try to keep the lid of the cryostat closed, so that you don't, the temperature inside the chamber is optimum. And that optimum temperature is the -20 to -30. Yeah.
Thank you, Christine.
Welcome.
The last question here on the chat as we wind up. Imelda Ochieng, though the question you have partly answered, but let me just read it out. When using a cryostat procedure for frozen sections, what is the temperature of a cryostat machine maintained to freeze the section tissue? And the other question is, what is the freezing agent used?
The freezing agent. And normally they use the liquid nitrogen, but now the cryostat, I've said the temperature is -20 to -30. That is the optimum, but there are settings that you will, if you feel like you want to adjust, you can, but the optimum is -20 to -30. Liquid nitrogen, that is the freezing agent. Yeah.
Thank you. Thank you so much, Christine, for the wonderful presentation. So precise and so detailed with illustrations, and you've answered our questions so well, and we've well understood and elaborately. Thank you so much. And thank you for taking time to prepare these and present and educate us. Members, thank you so much. I would like to take this opportunity again to thank you for sparing your time to attend to this webinar. Just to remind you again that kindly encourage your colleagues, encourage your office mates and your friends that are medical laboratory scientists to join. The registration is seamless, very easy. Just write your full names, provide your correct ID number, KMLTTB registration, your personal email address, and you submit. You'll receive a link in your inbox, which will help you to get into the webinars. And remember that the sessions are KMLTTB accredited, and they attract 3 CPD points, and which are auto reported within 24 hours in your KMLTTB portal for those eligible participants. That is, if you've registered and if you've stayed up to 60% or listened up to 60% of the presentation. Then certificates of participation are usually also shared. And something else is that the webinars are usually streamed live on YouTube, our YouTube channel, via the Lab Medicine Society of Kenya, and also on, but participants are eligible for CPD points, only those who participate on Zoom. And then encourage all participants, we encourage all participants to sign up on our LMSK Learning Hub, and it's a one-time sign up, gives you seamless access to all future events and learning materials. The links are posted on the chat. If you look at the chat, the links are posted there for the hub and for the YouTube channel. If you look at the chat, the links are posted there. We really appreciate you for being here today, and would like to take this opportunity to just say thank you, and looking forward to seeing you in our next webinar on Monday, Wednesdays, and Fridays. I've been your host and moderator, Nelly Ogada. Good evening. Thank you all.